Hello and welcome to this lesson, Primary Sclerosing Cholangitis. So primary sclerosing cholangitis is defined as inflammation and fibrosis of extrahepatic and intrahepatic bile ducts. So in our biliary system, we have intrahepatic bile ducts, and these are bile ducts that are within the liver parenchyma. And we have extrahepatic bile ducts, and these are ducts that are outside of the liver parenchyma. So here in this disease, primary sclerosing cholangitis, we have inflammation of extrahepatic and intrahepatic bile duct, and it goes against the primary biliary cirrhosis, where we have only inflammation of extrahepatic bile ducts. And note that unlike primary biliary cirrhosis, here in primary sclerosing cholangitis, men are affected more than women. So men are twice as affected as women in this disease. Now, what are the presentations of primary sclerosing cholangitis? Here we have the same presentation as we have in primary biliary cirrhosis. So in the primary biliary cirrhosis and in primary sclerosing cholangitis, in both diseases, we have signs and symptoms of obstructive jaundice. So the patient will be presented with progressive jaundice, fatigue, pruritus, and pruritus is due to the fact that we have leakage of the bilirubin to the blood. We have anorexia, and also we have signs and symptoms of cholestasis. Cholestasis is when we have a stasis of the bile, which causes deficiency in the fat soluble vitamins, because for the digestion of the fat soluble vitamins we need bile in our system, in our biliary system, because they help for the absorption of the fat soluble vitamins. So when we have signs and symptoms, when we have chronic cholestasis, we are going to have signs and symptoms of fat soluble vitamin deficiencies. So what are those signs and symptoms? So we have four fat soluble vitamins. We have vitamin A, and deficiency of the vitamin A causes night blindness, dry skin, and susceptibility to infection. We are going to have vitamin D deficiency. So as the result, the patient will have bone pain, muscle weakness, rickets in the children, and osteomalacia in adults. Vitamin E is another fat soluble vitamin, and as the result of a vitamin E deficiency, the patient is going to have neurological symptoms like ataxia, peripheral neuropathy, and hemolytic anemia. The last fat soluble vitamin is vitamin K, and as the result of vitamin K deficiency, we are going to have easy bruising, prolonged bleeding, elevated INR due to impaired clotting factors. Another sign and symptom is actually in the advanced disease, where the patient develops liver cirrhosis. So in case of developing liver cirrhosis, the patient is going to have signs and symptoms of liver cirrhosis like ascites, coagulopathy, portal hypertension, and so on and so forth. And note that primary sclerosing cholangitis is highly associated with ulcerative colitis. So we are going to talk about this in following slides. Now, what are the diagnostic tools that we can use for the diagnosis of primary sclerosing cholangitis? The best tools that we use is MRCP. And in the MRCP, which is standing for magnetic resonance cholangiopancreatography, you are going to see segmental fibrosis of the bile ducts and saccular dilation between strictures. So here in this picture, here you can see that we have stenosis and segmental fibrosis of the biliary system, and in between what you are seeing is the saccular dilation between two strictures. So this is our first diagnostic test. The second diagnostic test is ERCP, which is standing for endoscopic retrograde cholangiopancreatography. And note that the liver biopsy is usually not necessary for the diagnosis, but if ERCP and MRCP is normal, then we are going to proceed with liver biopsy. So what we are going to see in the liver biopsy, what you are going to see is periductal sclerosis, and it gives you the onion skinning appearance, what you see here in this picture. Also note that the liver biopsy helps for the staging of the disease. Now, note that you have to exclude other etiologies that cause biliary obstruction, like stones and tumors or biliary strictures, if you want to make the diagnosis of primary sclerosing cholangitis. Now let's talk about differential diagnosis for primary sclerosing cholangitis. So number one, we have primary biliary cirrhosis. So in this case, the patient is going to have similar cholestatic pattern, but note that the patient is going to be positive for antimitochondrial antibody. So this is for primary biliary cirrhosis, very similar disease, but the only difference is that you are going to have positive antimitochondrial antibody in case of primary biliary cirrhosis. Number two is autoimmune hepatitis, and in this case the patient is going to be positive for ANA. The third differential is IgG4 related sclerosing cholangitis, and in this case the patient is going to have elevated IgG4 in the serum and they are going to respond well to the steroids. Number four is recurrent pyogenic cholangitis. This is usually associated with parasitic infections like Ascaris. And number five is cystic fibrosis. Cystic fibrosis can mimic signs and symptoms of primary sclerosing cholangitis since the patients have bile duct obstruction, but this bile duct obstruction is usually due to thick mucus that we have in cystic fibrosis. Number five, we have Wilson's disease, and here we have Cooper accumulation in the liver causing liver cirrhosis and bile duct injury. Number seven is alpha-1 antitrypsin deficiency. This can cause chronic liver disease and biliary abnormality. Number eight is cholangiocarcinoma and pancreatic cancers. But in case of cholangiocarcinoma, the patient can have radiologic signs very similar to primary sclerosing cholangitis. And in case of pancreatic cancer, the patient is going to have biliary obstruction and signs and symptoms of biliary obstruction. Now, what are the treatment options for primary sclerosing cholangitis? Number one, note that all the patients are going to be given ursodeoxycholic acid, and this is shown to be slowing down the disease progression. Also, we can do balloon dilation of the strictures, and here you can see how we do it. We insert a balloon into the biliary ducts, and we try to actually dilate it in order to relieve the symptoms. Another one is a stent, and we can do the stent for biliary ducts for symptomatic patients. And this is something that we do usually in the short term, and it's not going to work very well in the long term. The last option is cholecystectomy, and we are going to do this if intrahepatic bile ducts are not involved. Now, what are the prognostic factors? So here we have so many prognostic factors and criteria. For example, we have Mayo model, we have Swedish model, we have new Mayo models, King's College model, or multicentric, which is a revised form of Mayo model. But all of these models that actually predict the prognostic factor are based on few elements. So the age of the patient is very important here. Bilirubin level is going to be very important here, as well as albumin, which is an indicator for the liver cirrhosis, AST, and the ratio between AST and ALT, because this is showing the hepatocellular damage in the patient. And also one of the most important prognostic factors is appearance of new varices, because this is another index for the liver cirrhosis. And these are very good systems that we can use in order to predict the survival rate and the disease progression. Thank you for watching. See you in the next video.